Hello, this is a brief summary of Pompe disease.
Is a relatively rare genetic disorder affecting lysosomal glycogen metabolism. The disease is caused by an absence or reduction in the enzyme GAA. In the human body, glucose is a rich source of energy, which is either used or stored as glycogen. Most glycogen is located in the cytoplasm of the cell, but to a much lesser extent, some glycogen is present in lysosomes of skeletal and cardiac muscle cells. In a muscle cell, glucose molecules come together in long chains to form glycogen. Once inside the lysosomes, the enzyme acid alpha glucosidase, or GAA, cleaves the glycogen chains. A deficiency in the GAA enzyme level leads to an accumulation of glycogen in the lysosomes. This initially causes the lysosomes to swell, impairing cellular processes and damaging cell structures. Eventually, the lysosomes may rupture and release their contents into the cytoplasm, further damaging the cell. In some patients, microscopic samples of muscle tissue can have increased staining for glycogen. When this is prominent, as an infantile onset Pompe disease, enlarged muscle cells can easily be observed. In late onset patients, microscopic muscle abnormalities may be less evident or absent. The enzyme GAA is encoded by the GAA gene, which is located on chromosome 17. Children inherit two copies of each gene from their parents, including the GAA gene. Pompe disease develops only in individuals with abnormalities in both copies. Anyone with one abnormal and one functioning GAA gene would not develop Pompe disease, but would be a carrier of the abnormal gene, potentially passing it on to their children. When both parents are carriers, each child has a 25% chance of being healthy and free of GAA abnormalities. However, with each child, there is a 50% chance they will become a carrier, and a 25% chance of inheriting two defective GAA genes and thus developing Pompe disease. The typical clinical presentation of patients with infantile and late onset Pompe disease differs. Patients with infantile onset Pompe disease typically present with severe muscle weakness and loss of muscle tone, severe heart dysfunction, and respiratory impairment, usually leading to death by 1 year of age. Patients with late onset Pompe disease, in contrast, may present with a variety of muscle symptoms, including muscle pain, fatigue, or progressive proximal weakness. Respiratory dysfunction is also common. Overall, patients with this form of Pompe disease may have variable rates of symptom accumulation and disease. To learn more about Pompe disease, its underlying cause, plus diagnostic testing information, please go to www.pompe.com.
In this study, published in JACC in 2014, the authors showed that a wide spectrum of patients with neuromuscular diseases have persistent elevation of cardiac troponin T in the circulation alongside creatine kinase and CKMB. Importantly, cardiac troponin I was normal in these patients. The authors argued that the reason for the elevation of cardiac troponin T in these patients was the release of this biomarker from skeletal muscle and not the myocardium. The authors in this study also looked at the impact of therapy in patients with reversible skeletal myopathies. In this case of hypothyroid skeletal myopathy, it can be seen that with treatment with hormone replacement, creatine kinase, CKMB, and cardiac troponin T all decrease in synchrony. In contrast, cardiac troponin I was normal throughout. The same observations were made in a patient with statin-induced skeletal myopathy. Patients with neuromuscular diseases have persistent elevation of cardiac troponin T in their circulation. This can last for several years. However, it should be borne in mind that there is significant day-to-day variation in the level of cardiac troponin T in the circulation. This is particularly relevant when assessing these patients for the possibility of an acute coronary syndrome. This study by Wens and colleagues was published in 2016 in Circulation Cardiovascular Genetics. They looked at 122 patients with Pompe disease. They found that cardiac troponin T was elevated in 82% of patients, whereas cardiac troponin I was normal in all patients. They also found that CKMB was elevated in 59% of patients. Furthermore, they found that cardiac troponin T levels correlated with creatine kinase levels. They did not find any clinical evidence of a myocardial injury. The most important aspect of their study is that they were able to demonstrate the mRNA expression of cardiac troponin T in the skeletal muscle of these patients. Furthermore, using mass spectrometry, they identified cardiac troponin T protein in the skeletal muscle of patients with Pompe disease. Wens and colleagues also examined the effect of enzyme replacement therapy on the concentration of cardiac troponin T and creatine kinase at baseline and after 2 years of therapy. They demonstrated significant decreases in both cardiac troponin T and creatine kinase. The fourth universal definition of myocardial infarction document was published in 2018. The document recognized for the first time that there are differences between cardiac troponin T and cardiac troponin I. It recognized that cardiac troponin T may be released from diseased skeletal muscle. The key references cited in the document are shown here. We have discussed today two of these key references. We can summarize. Number one, cardiac troponin T is released by diseased skeletal muscle. It is not specific to cardiac muscle as previously thought. In contrast, cardiac troponin I is specific to cardiac muscle. In patients with skeletal myopathies, cardiac troponin T is elevated alongside creatine kinase and CKMB. Cardiac troponin I is typically not elevated in patients with skeletal myopathies. The study of Wens and colleagues shows that cardiac troponin T mRNA and cardiac troponin T protein can be identified in the skeletal muscle of patients with Pompe disease. Thank you and goodbye.